السلام عليكم ورحمة الله حبايبنا، حياكم الله وبياكم. تقبل الله صيامكم وقيامكم يا رب. نبدأ في يومنا الثالث في مؤتمر علاج العصب الآيدك إندو 2024. المرة هذه مع ضيفتنا العزيزة من المغرب الحبيب الدكتورة الغنية على التعريف، اللي كانت معنا السنة اللي فاتت، ولي عظيم الشرف وجودها معنا لثاني مرة في آيدك 2024. الدكتورة وهيبة من المغرب في محاضرة عن نون سيرجيكال ريتريتمنت، عن إعادات علاج العصب. طبعا طلبنا من الدكتورة إن المحاضرة حتكون باللغة الإنجليزية، بحيث أن قدر المستطاع تسهيلا للمشاهد، وبحيث أن المشاهد يقدر يفهم تفاصيل المحاضرة. طبعا المغرب العربي الكل انتم عارفين ان ياخذوا في المناهج التعليميه باللغه الفرنسيه، ولكن قدر المستطاع حاولنا ان نوصل الفكره باللغه الانجليزيه لتصل لكل الناس. وما فيش باس دكتوره لو حبيتي تستعيني ببعض المصطلحات الفرنسيه لاخوتنا المغاربه وكذا، فالمكان ملكك. طبعا اليوم حبايب عندنا 6 محاضرات. محاضره الدكتوره وهيبه الان، محاضره الدكتور محمد الجرباء من اليمن بعد ساعة من الآن، ومن ثم محاضرة الدكتور شادي بعد ساعتين من الآن، وليلا باقي المحاضرات بإذن الله. نبدو على بركة الله ونتوكل على الله، والمايك ملكك دكتورة، المساحة ملكك.
شكرا لك دكتور نبراس، شكرا كثير على هذه الاستضافة، ورمضان كريم مبارك سعيد لجميع الإخوان والأخوات اللي معانا اليوم. سعيدة جدا بكوني معك للمرة الثانية، وكنحييك بزاف على المجهودات اللي كتبذل صراحة. كتشرف بالمهنة ديالنا، وهادشي ما كي غير كيفرحنا مرة على مرة. يعني الله. كيف ما قال دكتور نبراس، إن شاء الله المحاضرة غادي تكون باللغة الإنجليزية حتى تعم الفائدة لجميع البارتيسيبنتس اللي معانا اليوم. أظن I can start ياك دكتور نبراس.
اوكي، توكلي على الله دكتورة. دكتور تقدر تستعيني بالشرح عربيا وانجليزيا، خذي راحتك.
اوكي ان شاء الله. انا العربيه الفصحى ديالي مازال متقونه، يعني غادي نفضل باللغه الانجليزيه ونستعين مره باللغه الفرنسيه.
توكلي على الله.
شكرا لك. شكرا دكتور نبراس ان شاء الله. So we will start this presentation today. It's going to be about the endodontic non-surgical retreatment, the key steps of this topic. So I can introduce myself. I'm Dr. Wahiba Legmou. I'm a graduate from the Faculty of Dentistry in Casablanca, Morocco. I'm a passionate of endodontics, and it has only been 5 years now that I have had this passion for this subject. And I'm now here to share with you my experience, and I hope that it will be beneficial for everyone. So firstly, we need to know that over 50 years ago, Professor Schilder elaborated the principles of the endodontic therapy. And the main goal is to eliminate bacteria and protein degradation. Not only that, but also to maintain this result in time by complete sealing of the canal space in order to prevent recontamination. And this is what will determine the success of our endodontic therapy. So studies have shown that the success of this treatment is between 86 and 98%. What will define this success is, in fact, some symptoms such as predominantly the absence of pain, the absence of inflammation, or the disappearance of inflammation and fistulas if they existed before the treatment, as well as the maintenance of the tooth in a functional and a stable condition within its alveolus in the oral cavity. From a radiological point of view, it's the apical healing and scarring of the apical lesion that can be noticed during a follow-up after the root canal treatment. But we need to know that this is not always achievable. We cannot always have this success. In fact, sometimes the apical periodontitis does not heal. Either the lesion enlarges or persists, or even a new lesion can appear. We are now dealing with an endodontic failure. And this failure occurs in 14 to 16% of cases after initial root canal treatment. Now, what about this endodontic failure? What are the causes, and also what are the symptoms of it? Now, the success or failure of our endodontic therapy is depend on what we call the endodontic triad, which is shaping, cleaning, and filling. This means that if one of these steps isn't performed correctly, this will affect negatively and hinder the rest of the procedures. For example, if the shaping was not correctly made, then neither the cleaning nor the filling can be satisfactory. This is why the respect of the principles of each step is mandatory in order to avoid any therapeutic failure. The main cause of our failure is mainly due on the presence and persistence of microorganisms. These microorganisms, when they persist, they will induce an infiltration, which will induce a periapical inflammation, causing a failure. Among the causes that will lead to this persistence of microorganisms, we can have like the cases of missing canals, the cases of perforations, the cases of the access cavity which is not properly made. Also in the cases where we have unsatisfactory shaping and unsealed filling, well, all these causes will lead to the persistence of microorganisms. And these causes will manifest themselves with symptomologies that can be clinical or radiological. So the clinical symptoms can either be persistent or new clinical symptoms. And generally, it's the pain that we can notice, spontaneous pain, provoked pain, or pain while chewing. We can also have more complicated cases where we have infections with abscess and swelling. From a radiological perspective, it's a radiolucent image that persists or enlarges, or even a new radiolucent image that can appear after the initial root canal treatment. Most frequently, these clinical and radiological symptoms can be absent. And in these cases, when there is an exposure of the endodontic space for over than 30 years, it is sometimes we can have the endodontic treatment which was made correctly, but when we have an exposure due to the loss of the coronal restoration or its fracture, or even in the cases of recurrent cavities, this exposure will lead to a reinfiltration of the canal space that should be redone in order to eliminate all this infiltration. For prosthetic projects, we can deal with cases that when the endodontic treatment is unsatisfactory and appears to be incomplete, then a tooth that has prosthetic purpose, it's in the context of prevention that we need to redo this treatment. Now, this question is very important. What about the surgical and non-surgical treatment? Well, to answer this question, non-surgical retreatment versus surgical retreatment, Tora Binjad and his collaborators conducted this systematic review, and was able to show that the surgical retreatment offers more favorable success rates than non-surgical retreatment. It also offers additional healing over time. Whereas non-surgical, whereas surgical treatments lead to more failure over time. So based on this data, we can say that if a failure case was treated using non-surgical conventional methods, we can have higher success rates, especially if the tooth affected is with no symptoms, and I mean with no periapical lesion, and also when the causes of this failure and the defect has been correctly identified and corrected. Now, it's for this reason that careful analysis and meticulous analysis is mandatory and crucial in order to detect and to know all the different parameters that can influence our retreatment procedure, and also to know the obstacles that we have and elaborate a plan of action that we should follow step by step. We should know that this retreatment therapy is a first aid therapy, meaning that in any case, we should evaluate this equation of risk benefits, because sometimes it can lead to failure and we will have to extract the tooth. Now that we have talked about the causes and symptoms of failure, we should know that when we are dealing with retreatment cases, there are many challenges that I've tried to summarize in this second chapter in two main categories, which are the endodontic anatomy and the endodontic access. Regarding the endodontic anatomy, we should know that the endodontic network is very complex. You should take a look at this picture because this is the reality of the canal network. It has fine irregularities and fine branches and tubules with lateral canals and isthmus, and mechanical and chemical preparation of all these areas is almost impossible. Now, this study addresses the same point. As you can see here, the areas that are in green are the areas that were not reachable with instrumentation. So this is after instrumentation, some areas were left intact and wasn't able to be prepared. And because of these limitations, now we have the limitations of preparation, limitations of chemical debridement, and also a limitation in filling these hard to reach areas. And because of that, it's inevitable to not have a healing of the periapical lesion after our retreatment. Our retreatment will be also more complicated given the diversity of the root morphology, the diversity of the intracanal configuration, which will depend on different factors such as the ethnicity and the gender. And all of these points of all of these elements will lead us to the conclusion that the complete removal of endodontic filling materials is indeed the main challenge in our retreatment therapy. So now that we have talked about this endodontic anatomy challenge, there is a second challenge that arises during our retreatment, which is the endodontic access. So the access to the endodontic space is not always easy, but it's rather much more complicated with the presence of crowns, ceramic crowns, metal ceramic crowns, and bridges. Also, we can have coronal restorations like screw ports and inlay cores that will make the access to the filling material even more complicated. We can also have fiber posts that will not be easy and evident to remove. And this is why we need to analyze the situation so closely. We need to know what we are dealing with, what are the obstacles that we have during our retreatment, and in order to elaborate a plan of action that should be meticulously followed step by step. So this is what will bring us to the third chapter of our presentation. Now that we know that the goal is to eliminate endodontic filling material that is inadequate and access the apical parts in order to clean the root canal space and have a better and sealed filling and restoration of our canal space. The steps to do so are summarized in these 4 categories. So the first step will be the radicular access. The second one is the apical access. The third step that we need to follow during our protocol is the final desobturation, and after that comes the final rinse. Now, how can we access this filling material in order to remove it? First thing first, visual aids are very mandatory. They are crucial and essential during this step. It will not only provide visibility, but it will also give less risk during our preparation and protocols of removal. These visual aids like microscope and loops will help us in detecting the defects that caused failure, like what we talked about in the part of failure causes, like when the access cavity is not properly made, when there is a missed canal, in cases of perforations. Well, using visual aids will help us strongly in this stage. We should also know that when we have this coronal restoration, we should pay attention to its quality. We should know we should see if it has gaps, if it's poorly made, and in order to correct all these defects, to have a better environment and sealed environment for an optimal isolation. Also, in the cases where we have a loss of coronal walls, it is mandatory to restore the tooth before any other step or preparation to provide a better condition to realize our access cavity and install isolation protocol. For coronal restorations, we can also have ceramic bridges, ceramic crowns, and these can be removed by sectioning techniques using abrasive diamond burrs and also transmetal burrs if we are dealing with metal ceramic crowns and bridges. For screw pots and inlay cores, well, the use of ultrasonics and traction system has been proved effective and efficient. This is like the system of WAMX that is a very interesting system in removing inlay cores. Now, regarding the removal of fiber posts, we can remove them and fragment it, and they can be fragmented in using drilling techniques and also with milling techniques using specific round burrs, specific endodontic retreatment round burrs, and also using ultrasonic abrasive tips. For the removal of fiber posts, we can also use the guided approach that will guide us in the removal and the detection of this restoration. All this should be used under microscope, of course. So now that we have accessed the filling material, now that we have removed the coronal and radicular obstacles, we are now in front of a filling material that is generally made of gutta percha and the sealer. So how can we remove this filling material? This study have evaluated the efficiency of different solvents in removing the filling material from the canal space. And the results have showed that there was no significant difference between these 4 solvents, but also that none of these solvents was able to remove the filling material completely. And in the same context, these studies have proved that indeed the use of solvents can help, but it only can help in the first stage of file penetration. Like in the insertion of files, the use of solvents can help strongly, but it may hinder cleaning and disobturation because it will make it even much complicated and harder, only because the use of solvents will make the filling material more viscous. When it becomes more viscous, it will stick more to the canal walls and even penetrate into the deeper irregularities in the canal system. These films are what's called the films of softened gutta percha, and it's for this reason that the use of solvent should be avoided as much as possible. Now, the endodontic instruments that can be used in the stage of apical access in order to remove the filling material, we have the nickel titanium instruments, the rotary instruments, that are several systems available. There are systems that are specific to retreatment and systems that are conventional and can be used for initial treatment. And to compare between their efficacy, this study was conducted, and it has shown that there was indeed no significant difference between conventional systems and specific retreatment systems. The only thing that I can add is that the use of larger diameters and hybrid techniques will help more in the removal of the filling material. And we should know that this other comparison regarding rotary versus reciprocation, well, this study showed that the use of reciprocation instrument systems is as effective as continuous rotary systems. They have the same effectiveness in removing the filling material. Just that no system was able to remove the filling material completely. Either it's a specific retreatment system, a conventional one using rotary or reciprocating movement. None of this system was able to remove the filling material completely. And this also can be dependent on other factors, like some preoperative factors like the root canal morphology, or it can also depend on some clinical factors that can be related and associated to the endodontic treatment, to the initial endodontic treatment itself, like the type of the sealer that was used. And to address this point, this study compared the retreatability of 4 sealers. 3 sealers were bioceramic sealers, and the other sealer is an epoxy resin-based sealer, which is the AH+. And it's in fact this last sealer, the AH+, that was found to be associated with more filling material. Now, besides nickel titanium instruments, we have ultrasonic tips. We have some tips that are specific to retreatment and that have shown their efficacy in greatly removing the filling material from the endodontic space. In this study that studied the clear sonic, they evaluated their efficacy in removing the filling material. they have shown that it greatly improved the removal of the filling material from the canal space. And as we can see here, this is a microcity analysis. And based on this, we can see that the first group, right on top, when we used only the rotary instruments. The second group is when we use rotary instruments along with the clear sonic. And the third group is when we started with the use of clear sonic and then followed it by the use of rotary nickel titanium instruments. And it's in fact in this last group that we had the lowest amount and the lowest percentage of residual filling material. And in the same context, these studies have proved that ultrasonic retreatment tips was greatly effective. They were the most effective, they were the fastest, and they were the ones which induced the least amount of apical debris extrusion. Now, what is the clinical approach? What is the clinical approach for this retreatment protocol? So as in the initial endodontic treatment, the respect of the crown down technique is mandatory. And this is for both biological point of view and also for mechanical point of view. We should always respect the 3 stages of the root canal, starting by the coronal third, followed by the middle third, and then the apical third. To do that, we will need both ultrasonic retreatment tips and nickel titanium specific or conventional instruments, rotary instruments. We should not forget that the use of stainless steel files, the K files, is very, very important. And these stainless steel files will not participate directly into the disobturation, but they will also serve as guides. They will secure the passage, they will secure a safe passage of the instruments that will follow them. And it's with this protocol and it's with this philosophy that we can have better results. Now, in this case, I lost my words. So in this case, I followed the same philosophy, and the first thing that I introduce is my K file. Once my K file is blocked and it reaches a certain length, I take my X-ray. So when I take my X-ray and it's at this point and at this level where my K file has blocked, that I introduce my my retreatment tip, ultrasonic retreatment tip, and also my my rotary file. My rotary files should not surpass this level in order to have less risk of extrusion and also to avoid any file separation. And it's with this that we can gain stability. You can see in this case, after the retreatment, we have a complete healing of the apical area. You can see that the last X-ray was taken after 2 years and 6 months. The tooth was functional, it was clinically stable with no symptoms, and the patient was able to go back to his dentist and to his doctor in order to redo the bridge in order to prevent any recontamination in time. So now that we have eliminated the obstacles and we have accessed the filling material, and also we have removed most of the filling material using ultrasonic tips and rotary instruments. This final desobturation step, is very, very important, only because it will consist in using supplementary methods. These supplementary methods will enhance the removal of the residual filling material in order to avoid any reinfiltration, because at this interface that exists between the residual filling material and the root canal walls, the presence of the microorganisms that persisted is very high, and this final step of desobturation will enhance its removal in order to eliminate and kill these persistent microorganisms, in order to have a better outcome of our retreatment therapy. So this final desobturation can be conducted with several systems, like the XP on the shaper and the XP on the finisher. These systems are single file systems used in a continuous rotary movement. And according to the manufacturer, these systems are made with and max wire alloy, and the XP on the shaper, as you can see with its snake shape, will give the instrument the capacity to expand in the root canal space when it's exposed to body temperature, and that way it will reach areas that couldn't be instrumented and cleaned with other instruments. Recently, there was a launch of FKG launched the XP on the rise retreatment, which is like the XP on the shaper, only the tip was made with another design in order to enhance the retreatment ability and the retreatability of this instrument. This is a very interesting instrument that I use daily in my daily practice. It's very practical, and as you can see here in this short video, I used it after the apical access. After I removed the filling material, there were some residual debris that were able to be removed using the XP on the shaper. Now, this is another system, also very, very interesting in this final desobturation step, which is the self-adjusting file. And as its name indicates, it adapts to the morphology of the canal. It's like a sponge. So when you introduce it into the canal, it scrubs the canal walls, and it's also a delivery system, an irrigation delivery system that will allow better cleaning and an optimal disinfection and removal of the filling material. Its efficacy, the efficacy of the self-adjusting file was evaluated in different studies, and it has showed that it greatly improved the elimination of the residual filling material. And as you can see in the first group, A, where they used only rotary nickel titanium instruments, and the second group where they used rotary instruments along with the self-adjusting file, and we can notice that it has enhanced, it has improved the quality of our desobturation. Ultrasonic and sonic systems and devices are also very interesting at this stage. We can also use the gentle wave system, which is a multisonic system, and this system is in fact an irrigation system that was developed in order to clean the canal space with minimal shaping procedures. It induces hydrodynamic cavitation that will generate a broad spectrum of sound waves in order to reach the finest irregularities in our canal walls. And these instruments, the ultrasonic tips and the gentle wave system, has proved their efficacy in the retreatment protocol, and especially in the final desobturation step of our retreatment protocol. And with their vibrations, they will cause an acoustic treatment and cavitation bubbles that will generate and cause the displacement of this filling material that was kept attached to the canal walls. Also, there is laser. Laser has proved its efficacy in this step. Here we're talking in this study about the photon-initiated photoacoustic streaming technique, which is a new laser-activated technique that will activate the irrigant in order to penetrate the finer dentinal tubules and the canal walls. This system uses low energy erbium, and it has shown that when it's used along with rotary instruments, it greatly improved the removal of the residual gutta percha and sealer. Now we have arrived to the most important part. This is the final rinse part. So all this journey that we've had, all this journey of eliminating obstacles, of eliminating the filling material, we did that in order to expose the dentinal tubules where the microorganisms can be hiding. So this step is greatly important, and only because the main goal of our retreatment therapy is to eliminate these persistent microorganisms that manage to survive even in unfavorable environments, and that manage to escape the disinfection protocols. We should note that the microbial flora that exists in the primary infections are different than the microbial flora existing in secondary infections in cases of endodontic failure. So in this literature review, most authors highlighted the E. faecalis as the main responsible for endodontic failure, but other recent studies have isolated in a greater extent other bacteria like the Fusobacterium, the Candida albicans, and the Propionibacterium. And all these microorganisms and species have several properties in common, which allow them to survive in unfavorable environments. We can have the conclusion, and we can conclude that E. faecalis is not always the main responsible for failure, but it is important to know that it is almost always present in secondary infections with a prevalence that can reach up to 9 times. So E. faecalis is almost always present, and its presence can reach up to 9 times more in secondary infections, only because this species and this microorganism, this bacteria, has survival and virulence factors that are very specific, like the capacity to survive without oxygen, the capacity to survive without nutrients. It also resists intracanal medication and irrigation. It is able to form a biofilm, and it has the capacity to invade the finest irregularities in the canal network. So now that we have talked about our enemy, which are the bacteria, the microorganisms that manage to survive, and we have known its capacity, we should know how we can fight it, and we can fight it with our irrigation solutions. And as we all know, sodium hypochlorite is the main and gold standard irrigation solution due to its antibacterial properties, and also because it's the only solution with the capacity and the ability to dissolve organic matter and the organic components of the smear layer. The effectiveness of the sodium hypochlorite will depend on many factors, such as the concentration, the temperature, and also the contact time. Now, the sodium hypochlorite is amazing, but it cannot dissolve the inorganic matter. This is why we need a decalcifying agent, which is the EDTA or citric acid. These products will complement the effects of sodium hypochlorite in order to eliminate and remove the inorganic components of smear layer and expose the eliminate the debris and expose the irregularities and dentinal tubules in the canal space. The use of these decalcifying agents should follow the use of sodium hypochlorite. The chlorhexidine is very interesting only because it has a very interesting quality, which is its substantivity. The effect of chlorhexidine could be maintained until 28 days with only 5 minutes of exposure, meaning that the last irrigant that is recommended to use after irrigation is chlorhexidine. So after using sodium hypochlorite and EDTA to remove the smear layer, the last irrigants that is recommended to stay in the canal and should be used is chlorhexidine in order to improve the outcome and improve the antibacterial efficacy inside the canal. So studies have shown that when it's used as the last irrigant, lesser amounts of bacteria was found in the canal. To deliver these products and these solutions, we should use specific endodontic needles. And here we are talking about 27G or 30G needles that can be either metallic or like Irreflex or in propylene that has the ability to be more flexible into in narrow and dans les canaux coudés. Dans les canaux coudés, I couldn't remember it in English. Now that we have delivered our irrigation solution, we should activate it. The activation system with the ultrasonic tips and the agitation using sonic inserts is very important in order to create the bubbles and create a hydrodynamic cavitation inside the canal. Now, we should know that the use of all these irrigants is mandatory. They should all be used together. We should just know that they can interact and cause carcinogenic components, like the most dangerous interaction, which is the interaction between sodium hypochlorite and chlorhexidine. that causes a toxic and carcinogenic brown precipitate, which is the parachloroaniline. So the use of saline water alternating and between the irrigants is very interesting. So to avoid these interactions, there are what we call combinated irrigation, like the dual rinse, which is decalcifying agents. It's the EDTA with that can be compatible with sodium hypochlorite. So the use of this decalcifying agent with hypochlorite, sodium hypochlorite, does not induce any interaction. This is just a short video of how to use it. I had the opportunity to use it in my clinic. It comes in capsules. It's the ethydronate powder, that should be mixed with 10 milliliters of sodium hypochlorite. And now we can have a single irrigation solution that will have a antibacterial effect and dissolving capacity both on the organic and inorganic matter at the same time, and we can use it during and after instrumentation. Like the dual rinse, we also have the Q-mix, which is a combination of chlorhexidine with EDTA for a better antibacterial and smear layer removal during our retreatment. Now there is a question: after our irrigation protocol, after our final rinse, should we obturate and do the filling in the same session, or does it need to have multiple visits in this retreatment case? Well, this study showed that it's symptoms dependent, meaning that when we are dealing with a retreatment case that is with no symptoms, no clinical symptoms, no radiological symptoms, and I mean here, if we are dealing with a retreatment for prosthetic purposes, and because of a low quality root canal treatment, single visits can be done. But when we are having clinical symptomatology, like swelling and pain, it is preferable to use intracanal medication and delay the filling until the next visit. So this intracanal medication should consist of calcium hydroxide and also chlorhexidine, because it was shown that E-fecalis, that is almost always present in cases of failure, can have a resistance to calcium hydroxide, and as we saw earlier, chlorhexidine has shown that it's very effective in the removal and the elimination of E-fecalis. Now that we've discussed all these steps in the retreatment, we should now know that the final irrigation is the major step in this protocol. So this is just to summarize how we can perform this final rinse protocol. We need to have an intracanal disinfection, and to that we will use the sodium hypochlorite that we will agitate and activate using either manual agitation, sonic agitation, or ultrasonic agitation. Now that we have done that and we dissolve the organic matter, we should go and attack the inorganic matter and the smear layer using the EDTA at 17% or citric acid 10%, that we can also agitate and create hydrodynamic motion for it in order to reach and eliminate all the smear layer. And now that we exposed the finest irregularities, we can now attack the intratubular tubular disinfection using the chlorhexidine that is recommended to stay as the last irrigant. This is just a short video of how to use this this final irrigation. Here I used the sodium hypochlorite, and after that I activated with the underactivator, saline water, then a DTA, underactivator again, and then as the last irrigant, it's the chlorhexidine that I will not rinse, but rather I will just use paper points to remove it. And it's with this protocol, it's with the meticulous follow and respect of these steps that we can have a complete healing. This is after 2 years. The desobturation was made following these steps, and we can see that after 2 years we can have a complete healing, and the tooth is now a functional and stable condition with no inflammation. This is also just to capture the steps of the desobturation. This is also after 3 months. There were no symptoms. We can say that we had a good outcome and a success of our retreatment therapy. Same way, here we can see that only after 2 months we can have a healing of the periapical lesion using conventional non-surgical retreatment. I think that we have come to the end of our presentation, and I hope that it was beneficial for everyone, and that I have respected the time needed for this presentation, even though that it's a very wide subject, the endodontic retreatment. And thank you all for your attention, and I'm happy to be here with you today.
نورتي دكتورة وهيبة، جزاك الله كل الخير، ولينا عظيم الشرف بوجودك وبحضورك معنا في هذا الحدث. جزاك الله خيرا. طبعا من الحاجات الجميلة اللي صراحة والله ترفع لك القبعة عليها، الدكتورة اللغة الإنجليزية مش لغتها الأم، إلا أنها جدا 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 قوية فيها ومقوية نفسها فيها، وتقدر تنزل في أي ساحة بلغة أي شعب. فجزاك الله خيرا على كل هذا التعب اللي تعبتي عليه خاطرنا. نورتي، محاضرة كانت أكثر من رائعة، فشكرا لك من كل قلبي يا دكتور. الكلمة ليك لو تحبي تودعي المشاهد. دكتورة وهيبة سمعتني؟ دكتورتنا.
I think Dr. Nebras is following another presentation.
دكتورة وهيبة تسمع فيها ولا مش سامعتني؟ دكتورتنا يبدو انك منقص الصوت، فيبدو انك مش سامعتني. حننتقل طبعا من المغرب الحبيب لليمن، لجمهورنا اليمني اللي حيكون معنا. دكتورة وهيبة انا سامعك ونسمع فيك، يبدو انك ما تسمعيش فيا.
انا ما نسمعكش، لا.
اوكي، خليك معي على الخط على الموبايل، لان الان الكل يسمعوا فيك ومشاهدينك، وانا حاليا نسمع فيك، فخليك معي. طبعا ليك عظيم الشرف بوجودك معي دكتورة، ونورتي وانستي وشرفتي، ويا هلا ومرحبا بكل اهل المغرب الحبيب.
ربنا يخليك.
المحاضرة كانت في القمة، وطبعا غير المحاضرة اللي شدني فيها، مش المحاضرة اللي شدني شيء ثاني، وهذا ننصح به كل الزملاء المشاهدين واللي يتابعوني. اللي شدني هو ان لغتك الام مش اللغه الانجليزيه، الا انك قويه فيها جدا ومقويه نفسك فيها، وتنزلي لكل ساحه وكل ارض بلغتها. فتحيه لك.
ربي يخليك. شكرا لك. شكرا.
صراحه مبسوط وممنون جدا بوجودك معاي، وان شاء الله يا رب تكوني لنا كلنا قدوه في تطوير الذات وفي تطوير النفس باذن الله. وباذن الله
شكرا لك دكتور.
ناخذ الفرنسيه وجايكم في المغرب نعطيكم المحاضرات بالفرنسيه باذن الله.
ان شاء الله ان شاء الله ان شاء الله
ينور موفقه يا رب.
فرحانين ان شاء الله
الله
بوجودك
ينورك
معنا في المغرب.
لكل المغرب العربي ولكل اهلنا وناسنا وزملائنا في المغرب العربي. محاضره جدا جدا ثمينه وقويه من المغرب الحبيب. حاليا ترتفع رايه اليمن عاليا مع الدكتور محمد الجرباء. بعد 5 دقائق حنكون في المحاضره باذن الله. تحياتي لكم. المايك ملكك دكتوره، لو تحبي تودعي المشاهد احنا سامعينك.
شكرا دكتور نبراس على الاستضافة مرة أخرى، وشكرا على جميع المحاضرين اللي متبعين هذا المؤتمر القيم. وكنحيي جنود الخفاء اللي كيقوموا بهذا المؤتمر اللي هو بقيمة جد عالية وبمجهودات رائعة. شكرا لك دكتور نبراس على نشر العلم وعلى نشر هذه المعرفة، وأنا كنت جد سعيدة بوجودي معكم.
الله يبارك لك. ولا ننسى إخوتنا في غزة من صالح دعائنا، نسأل الله أن يفرج همهم يا رب ويحفظهم بحفظه كامل مستديم. نلقاكم بإذن الله بعد دقائق مع اليمن الحبيب في محاضرة أول دكتور يمني معنا، الدكتور محمد الجرباء. طلب صغير من الدكتورة وهيبة نشوف فيه في التعليقات ان المحاضره تبقى محفوظه دكتوره اذا كان ما فيش اي احراج في الموضوع.
ما في اي مشكله. with pleasure.
ما في اي مشكله. صاحبه اصل وواجب. مع الف سلامه. نشوفك على خير باذن الله. السلام عليكم ورحمه الله. ما تنسوش التسجيل في رابط التسجيل يا شباب. ونلتقي بعد 5 دقائق في محاضره الدكتور محمد جرباء. السلام عليكم ورحمه الله.